preceded him in the Congress, and he was chair of this subcommittee. So the tradition continues.
Oh,
You're recognized.
we care a great deal about these issues, Madam Chair. Thank you, as you do too. Thank you very much. Well, I have some prepared questions, but I was looking into HR 2035, and I wanted to, for the benefit of the people listening back home, tell me what it encompasses. I'm concerned specifically, is it Medicare, Medicaid patients who are severely, have severe illnesses? I'm also specifically concerned, do wounded warriors, I know it's mentioned in the bill with regard to wounded warriors, do they qualify for the respite care? In other words, they're caregivers? That's so important as well, please.
What's unique about Lifespan Respite Program is that there are no stringent eligibility criteria. So this enables the state to identify where the biggest gaps are in services and try to target their limited dollars to those individuals. So folks like wounded warriors, and there is a VA program for respite, but very often these individuals are either not qualifying for the VA program, or there are not the types of respite options, especially the younger veterans, where they're comfortable getting respite services. So we have continued to partner, especially at the state level. The state respite coalitions have invited the VA caregiver coordinators to participate in their coalitions so that they can find additional respite resources for those individuals. So again, there's not a specific targeting. If a state is providing consumer-directed respite vouchers, they're very often targeting it to adults between the ages of 18 and 60, or with conditions like MS or ALS or spinal cord injuries, or adults with intellectual and developmental disabilities for whom no other respite services or public funding sources exist. People with mental health issues where it's very hard to find respite services or dollars to support that. Families who are on Medicaid waiver waiting lists are often the first to be served under lifespan programs too. So it's the gap filling program. It's those respite services. Families are eligible if they're not getting services anywhere else from any other public program.
All right, very good. Yeah, so it's basically up to the states. Okay. Dr. Brachini, as lead sponsor of the Congenital Heart Reauthorization Act, which is now law, and the co-chair of the Rare Disease Caucus, I certainly understand the importance of early screening and the critical chance and hope it affords patients and their care team. What's the current state of newborn screening? Does it vary from state to state? I want to ask this question specifically. I know it covers hearing loss. In other words, the baby is screened for hearing loss. How about visual impairment? Does it cover that as well?
Visual impairment is not covered by newborn screening.
We have to do something about that.
Well, there are a number of things that are considered to be practice parameters that all babies are screened for in the newborn period by physicians and are not part of the public health program. The public health program for newborn screening is really dedicated to things that can be done in a public health laboratory, as well as hearing screening and critical congenital heart disease screening are point-of-care tests, and those are the only difference then, other than the blood heel stick blood test. So certain things would be considered normal practice parameters and out of the public health realm.
Okay. So you answered most of my questions here. Screening without proper follow-up actions is so very important. If you don't have the follow-up actions, it's basically moot. After an initial newborn screening identifies a condition, patients or the caregiver, in this case, the education options and resources become critical, especially in rural areas and low-income areas and medically underserved communities. What does that handoff currently look like? Is there room for improvement to follow up? Because that's so important as well. If you could maybe elaborate a little bit, sir, that's important. We follow up.
Thank you. It's a very important question. Newborn screening is a program. It's really not a single test that's done in a laboratory. So it's very important that children who are identified are rapidly referred to the specialist or the individual who can then manage that child's care. So we would call that short-term follow-up. And then once short-term follow-up is assured, the diagnosis is made, and then the management is evolved, then long-term follow-up becomes really important so that that child's not lost to follow-up. Yes, we can improve that. There are a lot of gaps that may exist in individual states based on resources, based on having enough subspecialty providers to take care of those patients, and then having the resources for the care that's needed surrounding that specific diagnosis. So I think there is an opportunity with this reauthorization to have more funds go to states through the HRSA program to help improve short-term, long-term, especially long-term follow-up of those patients.
All right, very good. I yield back, Madam Chair. Thank you so
The
much.
gentleman yields back. The chair recognizes Dr. Ruiz from California for his 5 minutes of questions.